Hi, welcome to an overview on pre-hospital trauma care. Historically, the development of trauma care and trauma care systems is based on the experiences provided by conflict and war situations all over the world. The military emergency care has led the way to the systematic approach to trauma care for the severely injured patient. In this talk, we shall be broadly reviewing the concepts related to pre-hospital trauma care and touching upon some salient features which would highlight the need, the basic approach, and some evolving concepts related to it. The concept of the modern pre-hospital care system for trauma patients goes back to the introduction of the flying ambulances by Napoleon's private surgeon, Dominique John Laurie, in 1792. These ambulances were horse-drawn carriages bringing physicians or medical supplies to the battlefield and transporting wounded soldiers away from frontline using a scoop-and-run concept. All modern EMS systems still follow this early idea of either bringing the physician to the patient or bringing the patient to the physician. While the history of our modern EMS system is a relatively short one, there is no shortage of individuals who have proven to be heroes in regard to their commitment and passion for advancing the pre-hospital profession. Their accomplishments, from establishing standardized training for providers to improving pre-hospital cardiac resuscitation to creating better system management, has helped move EMS forward. Many individuals have taken personal and professional chances on fledgling ideas in order to build systems they believed would save lives, hence allowing the next generation to build down a foundation with clinical, operational, and administrative improvements that has helped EMS survive and thrive. History is full of numerous work and effort put in by various individuals. In 1865, the first known hospital-based ambulance service operated out of Commercial Hospital, Cincinnati, which is now a Cincinnati Journal. It was modeled on a military-style command and discipline structure. The St. John's Ambulance Brigade was established to provide first aid and ambulance services at public events in London in 1887. In 1881, the earliest emergency medical service was reportedly the Rescue Society founded by various people. This served as a model for similar societies worldwide. That brings us to the question about why we need it. Prevention of trauma is the first and foremost important component of trauma care. Pre-hospital care can intervene in the second peak of trimodal death distribution of trauma, in which 1/3 to almost half of all trauma deaths occur. It can definitely reduce the impact of trauma on both the personal and community level, and generally the best way to reduce rates of death or disability from life-threatening injuries. However, it is often possible to minimize the consequences of serious injury, including long-term morbidity or mortality, by promptly providing effective pre-hospital care. The topic itself on pre-hospital trauma care is definitely challenging, and doing justice is a big task. Difference does exist among different regions and countries based on available resources and systems. Talking about chain of rescue, it is the optimal trauma care which begins at the site of the accident and ends with a good rehabilitation program, and can only be achieved if all parts of the chain deliver excellent care and interact effectively. In the Western world, there are two prominent models of pre-hospital care system: the Anglo-American, which is basically provided by the emergency medical technicians and paramedics, and the Franco-German model, which is basically a physician-based system. The comparison between them is still a subject of ongoing discussion. Now, regardless of how simple or sophisticated a given pre-hospital care system might be, there are certain elements that are essential in order to decrease preventable morbidity and mortality. These elements include, at a minimum, prompt communication, activation of the system, prompt response of the system, and then the assessment, treatment, and transport of the injured people to formal healthcare facilities when necessary. Whenever and wherever possible, existing clinics, hospitals, and health services should be utilized to ensure efficient mobilization of healthcare resources. This is as true in remote or rural areas as in more urban areas. With regards to documentation, the key elements of data needed include who, what, when, where, and how. Each episode of care should be documented not only because it is important, but it is also important to monitor the processes and outcomes of care, and also because the incident records provide important insights into the nature and location of community hazards and how many injuries might be prevented. Documenting those pre-hospital care is essential to develop a sustainable system as well as assist in evaluating the system, the preparedness, and hence the quality assurance. Now, these systems differ with respect to the level of care provided, the personnel delivering the care, and the mode of transportation. Variables that can influence the decision are local availability of the resources, distances, injuries, and the status of the patient's vital functions. There is no conclusive evidence substantiating which system is best with respect to outcome of the trauma patient. Now, with respect to the pre-hospital interventions, different types of controversial concepts have been discussed worldwide, often described as scoop and run and stay and stabilize. The overall aim is to save time until hospital admission or definitive care. Now, supporters of this concept of scoop and run believe that if a trauma patient is in danger, it is because of the uncontrolled hemorrhage. The airway and breathing should be secured if necessary, and starting IV lines and replacing large volumes of fluids are unnecessary as it will cost time, increase bleeding and coagulopathy, and thereby may worsen eventual outcome. However, the overall aim of stay and play is to secure oxygenation, airway and breathing should be controlled, and early intubation should be initiated. Volume should be replaced in order to maintain organ perfusion, and time hence is not considered to be the primary focus. Goals of pre-hospital trauma care basically is to detect life-threatening injuries, treat them as soon as possible, triage, and save time until definitive care. Now, the main goal, including pre-hospital emergency care in the system, is to transport the injured patients to the most appropriate acute care facility as quickly as possible in the best possible condition. The advanced trauma life support provides a well-established and accepted concept of rapid evaluation of the trauma patient at the scene, which basically begins with general impression and initial assessment consisting of a primary and a secondary survey. Now, formal algorithms or protocols must be developed to ensure that community resources are used properly to care for trauma patients. These algorithms must exist for both the pre-hospital setting as well as the hospital setting. Failure to develop such protocols may lead to over-triage or under-triage. Triage to the most appropriate hospital is important because patients who were secondarily transferred within a trauma care system have a 30% increased risk of mortality in comparison with the patients who were transported directly to an appropriate facility. Let's quickly review the basic concept of primary survey. It basically addresses checking the vital status and finding out if there is a problem with A, B, C, D, and E. Primary survey begins with detecting a life-threatening airway problem, for example, a GCS less than 8 to 3. Now, emergency medical services personnel must be trained in an emergency anesthesia like endotracheal intubation as well as securing airway with a bag valve mask, a supraglottic airway devices, or even an emergency cricothyroidotomy. Life-threatening breathing problems must be detected, such as tension pneumothorax or hemothorax, as they can result in a cardiorespiratory impairment. A fast needle decompression followed by a placement of thoracic drain is usually the case. Changing and emerging concepts can be found in literature. For example, a study by Inaba et al. Have tried comparing an optimal site for needle decompression for pre-hospital care providers. They suggest that fifth intercostal anterior axillary line can be localized and decompressed with a higher degree of accuracy than the traditional second intercostal space midclavicular line. Basic idea is to standardize the procedure and make it more effective, especially in pre-hospital care setting. Now, there has always been a traditional emphasis on airway management, and hence it remains an active area of interest. And early appropriate airway control remains central to a good trauma management. Which bring us to the life-threatening C problems, which is an uncontrolled bleeding. As we all are aware, areas to look for sources of bleeding are abdominal, chest, pelvis, and long bones. Control of bleeding is crucial. Pressure or tourniquet application in pelvic binders have been used for the tamponade and control. Tourniquets are experiencing a revival after they were all but eliminated in almost early 80s, when the fear of extended soft tissue damage, nerve damage, and potential loss of the extremity was feared if it was used for too long. The different injury pattern experienced by the US military in the latest conflicts in Iraq and Afghanistan showed that tourniquets save lives in cases of severe blast injuries to the extremities. Now, with respect to the hemorrhage, administration of large amounts of fluids have been shown to deteriorate outcome by increasing the blood loss because of increased blood pressure and impaired coagulation. Fluid resuscitation has been an active source of debate with regards to pre-hospital care. Varied things have been tried in different setups and is a part of ongoing debate. Some other forms of hemorrhage control include advanced hemostatic dressings and granular agents, for example, Hemocon bandages and quick clot. Examples of granular agents are Celox and Woundstat, to name a few. Military comparisons of these agents show better control of hemorrhage when compared to swine models, and a lot of research is still ongoing with regards to the control of hemorrhage with these. Let's digress a bit to discuss some new and novel approaches to fluid resuscitation in pre-hospital trauma care. These are just few examples just to show the amount of effort being put in to come up with so-called ideal combination or best management for a bleeding trauma patient in a pre-hospital setup. It would not be wrong to say that at the moment there is no one right answer. Studies are showing better outcomes with blood or blood products transfusion, hence should be considered wherever possible. What is important to understand is the trauma patients in a war or military settings may have a different physiology when compared to a civilian setup, and the outcomes and approach would perhaps be different. The literature available should be reviewed and understood on the background of the pre-hospital care and resources available in that particular region or setup. This brings us to the disability. Life-threatening deep problems, including signs of increased cranial pressure, any deterioration in patient's consciousness, and abnormal pupillary reaction. GCS 8 or lower, by definition, patient has an airway problem and needs endotracheal intubation. Do take into account the GCS of the patient while assessing the disability, where the best possible score is 15 and the worst being 3. For the life-threatening E problems, consider the environmental hazards and exposures like hypothermia, exposure to toxic agents, and inhalation trauma. If the patient has a penetrating injury, like a stab in the chest, it is appropriate to leave it in situ. Now, once primary survey has been done and it's in control, a quick secondary survey is done, which is a head-to-toe survey of a quick body checkup. It basically looks for relevant anatomic injuries like unstable pelvis, spinal fractures, long bone fractures, and neurovascular injuries. In any unconscious or intoxicated patient, spine injury should be suspected. at the level of the cervical spine, collar or sandbags or any immobilization device, and for the thoracic and lumbar spine, spine board or vacuum mattresses should be used. The EMS team make a decision as to which hospital the patient should be transported and how. The aim is to get the right patient to the appropriate hospital in time. The evidence available suggests that severely injured patients have a better outcome when treated in trauma centers. All experts unanimously agree that the pre-hospital time should be as short as possible, and interventions should only be performed if indicated and not as a principle. The controversial discussions regarding the different approaches of scoop and run versus stay and stabilize seems to gravitate towards the treat and go approach. Having said that, this may vary from region to region. The system models. Now, different system models exist. The model itself may determine which individual or agency is best suited to administering the system. That may include hiring personnel, financing the system, training of the pre-hospital care providers, quality assurance audits, managing communications, etc., etc. At the community or regional level, a variety of approaches have been used to develop, organize, and regulate pre-hospital systems. It is complex setup and has multiple facets, and indeed there can be a separate discussion just on the systems and models of the pre-hospital care. Very briefly, I would like to mention the different types of pre-hospital systems that are there. Starting with the national systems, they may be designed, developed, and controlled by a country's central governmental authority, for example, the Ministry of Health. The local or regional systems are in line with other public safety agency like municipal hospital systems. They're administered by a local or regional governments, and they may use existing infrastructure like a police, fire, or public health systems, or a separate non-profit infrastructure, for example, non-profit authority, to deliver the pre-hospital care. Private systems, emergency medical service companies operating either as non-profit or for-profit organizations, they may contract with authorities to provide pre-hospital services throughout a specific neighborhood, city, or region. Then there are hospital-based systems, which are often the simplest to establish and maintain because they utilize the personnel, resources, and infrastructure of a central or a referral hospital. The hospital and its staff govern all aspects of the system. Volunteer systems are also very common, and they depend on pre-hospital providers who donate their time and services to their community. This model is particularly common in rural and remote areas. For hybrid systems, many systems combine components of the models described above to provide pre-hospital care for a particular community. The decision about whether to combine different models depends on the local political, financial, and administrative concerns. The concept of resource utilization is basically the community members and non-medical professionals who can be trained to work collaboratively within a country's existence healthcare system, especially the remote areas. Now, the infrastructure is to provide a basic level of pre-hospital care to the people who are seriously injured, and that it is possible to do this thing affordably. This idea is not new. Community members in Africa and South America have been successfully trained to provide effective emergency care using locally available resources. I apologize for the busy slide. It is just one of the myriad examples quoted in literature on different model systems of pre-hospital trauma care, ranging from volunteer community members to paramedics to trained ALS doctors, varying from region to region and country to country. As quoted, one of the most basic ways to provide pre-hospital care is by engaging the community members. Involving them in the process may have the additional benefit of helping them identify and address hazardous conditions and behaviors in their local environment, and thus promoting trauma treatment may further the goals of injury prevention. As we've discussed different forms of pre-hospital care available, with a few exceptions such as early defibrillation for victims of cardiac arrest, most advanced interventions have not been scientifically proven to be effective because the necessary randomized trials have not been conducted. In contrast, improved outcomes have been documented after bystanders and healthcare providers have been educated to provide the fundamental elements of trauma care. Would I would definitely like to quote an interesting incident about famous Kerry Francis Packer, who was an Australian media tycoon and outside Australia was best known for founding World Series cricket. In 1990, while playing polo at a farm in Sydney, he suffered from a heart attack that left him clinically dead for 6 minutes. Packer was revived by paramedics and then shifted to hospital where he received a bypass surgery. It was not uncommon for an ambulance at that time to have a defibrillator, and it was purely by chance that the ambulance over there had one fitted. After recovering, Packer donated a large sum to the Ambulance Service of New South Wales to pay for equipping all ambulances with a portable defibrillator, now called as Packer Whackers. It would be appropriate to emphasize on how important it is to allocate the appropriate resources for the setup of a proper trauma care system and hence a pre-hospital care. The focus should be on minimizing the on-scene time and decreasing the time to definitive in-hospital care. Before we end, a food for thought after this very broad overview and rather abridged talk. Literature is full of ongoing debate and controversial discussion for the best form of system. Opinions range from developing countries having no formal pre-hospital established system to a developed country where the concerns are rather different. The results of the study show that the use of on-site ALS in general does not provide any benefits in reducing mortality in patients with major trauma. This result is generalizable to patients injured in urban centers served by highly organized trauma care systems with access to a level 1 trauma center. Yet to find hard evidence on an ideal form of care leading to improved mortality and morbidity. I believe this field will continue to evolve and best understood in a dynamic form with changing needs and trends in a particular setup. Thank you very much and have a good day.